All right, so in this section, we'll look at the various characteristics of tumors. So the rates of growth, the modes of growth, whether tumor invasion, true lymphatic spread, hematogenous spread, transcelomic spread, and we'll also look at metastasis, which will focus on the staging of malignant neoplasms too. All right, so the rate of growth, generally benign tumors grow slowly, though some benign tumors grow very fast. For example, in hemangiomas, and malignant tumors grow rapidly, um, and then spread throughout the body and will kill the patient if there's no medical intervention. So the factors that affect the growth rate includes hormone dependence. For example, leiomyomas increase rapidly during pregnancy due to estrogen and progesterone secretion, and also adequate blood supply and other idiopathic factors or unknown factors could affect the rate of growth. So the effects of rapid growth of tumors include necrosis, which occurs in tumors when they outstrip the blood supply. Ischemic necrosis is very common in malignant tumors, and hemorrhage too may occur due to necrosis or disruption of a blood vessel, and it's commoner in malignant tumors too. Alright, so the rate of growth depends on doubling time of the tumor cells, the growth fraction, and also cell attrition. And the doubling time, a cell of size 10 microliter meter diameter needs about 30 population doublings to become clinically detectable. That's like 1 milligrams of tumor, and 10 further doublings, like 1 kilogram of tumor, which is got to the maximum size of the cancer compatible with life. So most tumors become clinically apparent when a major portion of their lifespan is over. So the growth fraction, that one, the proportion of cells proliferating at any time is the growth fraction, and this is high in early phase of tumor growth and low in the latter stage when clinically detectable. By the time a tumor is clinically detectable, most cells are not actively proliferating, and high growth fraction tumors, about 20%, include leukemias, lymphomas, small cell carcinomas of lungs, and nasopharyngeal carcinoma too. So low growth fraction tumors, about 10%, like carcinoma of the colon, could also and salivary gland carcinoma, but the rest are in between. So growth fraction affects susceptibility to chemotherapy, which acts on the cell cycle, and a high growth fraction means many cells are dividing and are more susceptible to chemotherapy, but low growth fraction tumors are less so. So to overcome this, surgery is one thing that has to be done to remove as much tumor as possible. That is the debulking before chemotherapy, and this removes cells that may not be susceptible to treatment and also activates those left behind to divide and become more susceptible. So cell attrition actually refers to cell loss through death of cells, and growth would occur only if proliferation exceeds attrition. So the mode of growth, benign tumors grow in cohesive expansile masses and have a rim of compression or compressed connective tissue that forms a fibrous capsule. So this capsule is formed from host tissue, which is left behind as host parenchymal cells die from pressure atrophy. And benign tumors are therefore discrete, well circumscribed, and readily palpable movable masses. There is no local invasion. Malignant tumors grow by progressive infiltrative means or infiltration, has invasion and destruction of surrounding tissues. Local invasion gives a poorly demarcated tumor which lacks a well defined plane of cleavage. Alright, so comparison of the benign and malignant neoplasms. Note that for a benign tumor, the there is exophytic growth, the homogeneous cut surface, well circumscribed or encapsulated edge and in-cut surface. But for malignant, there's heterogeneous cut surface due to necrosis or serrated surface could be present, and endophytic growth could also be present, and there is vascular permeation and irregular infiltrative edge too. And those are the principal differences in the gross morphology of benign and malignant neoplasms too. So for tumor invasion, epithelial malignant tumors starts as in situ carcinoma with malignant cytolytic features but no breach in the basement membrane. The next stage is microinvasion, followed by frank invasion and then distant metastasis. Next to the metastasis, there is invasiveness, and then this invasiveness is the most reliable feature that differentiates malignant from benign tumors. Alright, so for hemotypic cell adhesion, the normal cells, E-cadherins are present, and with the malignant cells, there's downregulation of E-cadherin. So attachment of the tumor cells to the basement membrane and extra matrix components by integrin receptors are being altered. A typical tumor cell, the laminin receptor is attached to the so let's take the basement membrane. You have your type 4 collagen, you have your laminin attached to the laminin receptors, which is also attached to the tumor cells. So the tumor cells releases the protease enzymes to dissolve the matrix, which leads to the cell movement too. So metalloproteinases like the collagenases, gelatinases, stromycins, heparinases, serine-dependent proteases, thiol-dependent proteases, and others like the plasminogen activator from the tumor cells also affects the rate of malignancy or the carcinogenesis of these particular tumors. So there's active movement of the malignant cells, and invasion and metastasis requires active movement of these tumor cells, both random and directed. Random being kinases and directed being the taxis, which is promoted by the intact or fragmented extracellular matrix molecules. So the fibronectin integrin binding to the RGD sequence on the fibronectin. Well, what happens is it gets into the extracellular matrix and facilitates or activates its movement, causing more aggressiveness or making it more malignant. Alright, so when it comes to neoplasm and neoplasia invasion, the undifferentiated cells lose cohesiveness and acquire the ability to invade neighboring tissues and blood vessels, leading to dissemination. So there is erosion of the basement membrane, the tumor gains access to the vascular channels, the cells escape from the tumors via the lymphatics, and there's secondary tumor in the lymph nodes too. Alright, so a typical adenocarcinoma of the colon invading the muscularis propria, like I described in a former tutorial. You see all these mitotic, the H&E staining. You could see all the features I talked about in the previous tutorial. And with the local spread, you could see there's a direct extension into the surrounding tissue, which may cause local tissue destruction with necrosis and hemorrhage, and also perineural invasion and permeation of tumor cells along the perineural sheath. So lymphatic spread is the most common pathway of carcinomas, and these sarcomas use this route less frequently. Nodal involvement follows natural routes of drainage of the sites of the tumor. For example, when you take breast cancer, the upper outer quadrant. Of course, you have the axilla, so axillary lymph nodes are being um, implied over here, so implicated over here. Inner quadrant, there is internal memory nodes too. So the lymph node serves as a barrier preventing spread, including that's during which time the tumor may be destroyed by the immune response. So the lymph nodes, you have the tumor invades, or the cells invading the lymph nodes. So most tumors, especially carcinomas, use this pathway, right? And with the gross appearance of a metastatic deposits in para-aortic lymph nodes, it's, you can see what the features I discussed earlier on. So blood or hematogenous spread, one is typically used by sarcomas, and some carcinomas also spread by this way. So by tumor embolism, it's the commonest path, and this via venous channels to the liver, via the portal veins, and to the lungs via systemic veins. And the tumors close to the vertebral column spread through paravertebral plexus of the veins to the vertebral column. For example, in prostate carcinoma, so seeding of body cavities and surfaces like transcelomic, that one, it occurs when the tumor penetrates into a cavity, for example, peritoneal, subarachnoid joints, and several others, following invasion of serosal lining, and local inflammatory response to infiltrating tumor cells too. Okay, so malignant cells incorporated into the inflammatory exudates too follows, and small groups of cells detach and sweep away by the fluid portion of the exudate into the serosal cavity and settle on the walls of the serosal cavity. Some proliferate into the secondary deposits and elicit more exudation, for example, fluid accumulation in cavity. For transcelomic spread, it often occurs in the peritoneal cavity, for example, peritoneal carcinomatosis. They may occur with appendiceal tumors that secrete mucus, and pseudomyxoma peritonei, and gravitational seeding from gastric and colonic carcinoma with involvement of ovaries. There's enlarged ovaries with smooth muscle capsule with stromal desmoplastic reaction, and that is the Krakenberg tumor. Alright, so implantation, the tumor cells can be implanted along a needle biopsy track or surgical incision. Alright, so talking about metastasis, what is even metastasis and how will you define it? So with malignant cells established at a point distant from the original primary lesion with no continuity between them is metastasis. So the tumor implants discontinuous with the primary tumor is metastasis, and the mechanism is from secondary to lymphatic invasion, secondary to blood vessel invasion, or seeding out across the serosal lined spaces. So metastasis is basically an embolic process involving liberation of cells from the primary tumor mass, invasion of the blood vessels or lymphatics, transfer of tumor cells as emboli, adhesion of the tumor cells to endothelium on the vascular bed, migration from the vessels after impaction, survival at the new site, which requires angiogenesis and multiplication and growth to form secondary tumors. Alright, so with the processes in tumor metastasis, we have the primary tumor detaches, and there's migration of the malignant cells, there's transport of the tumor cells as microemboli into the vessels, and it attaches to the vascular, so adhesion to the vascular basement membrane, invasion of the venous, and final adhesion to the vascular membrane, cleavage of the membrane, and migration of the cells. All right, so the lung, breast, stomach, sarcomas, the malignancies follows the same pattern. And a typical liver with maybe hepatoma or hepatocellular carcinoma, or it could also malignancy could occur virtually whether in the GI pancreatic tumors, breast, genitourinary malignant melanomas and sarcomas. A typical um, hepatocellular carcinoma hepatoma has been described in a previous image, and could also have that in the brain too. Okay, and there could be metastatic deposits in bones too. All right, so like I said, the summary of the mechanisms of the tumor spreading metastasis. The basement membrane carcinoma in situ, the cancer cells becomes capable of invasion, expressed on the surface adhesion molecules. The tumor cells adhesion molecules bind to the underlying extracellular matrix, and then there's a release of proteolytic enzymes. The tumor cells disrupt and invade the extracellular matrix, the tumor cells. So there's a repeated binding to and dissolution of extracellular matrix to, so whether to the blood vessels or the lymphatics, and the tumor cells metastasize by way of blood vessels or the lymphatics. Alright, so that's quite simple. With the staging of tumor, assessment of the tumor spreads within the patient is based on the size of the primary tumor and the extent of the spread to the original lymph nodes and the presence and extent of the blood-borne metastasis. So the staging of the tumor is done by histological examination of the primary tumor and lymph nodes, in addition to the clinical assessment of the involvement of distant organs using the imaging techniques. So the staging systems are two major systems of staging of the tumors, and we already know we have the UICC and the AJCC. So the UICC has to do with the Union for International Cancer Control, which uses the TNM classification. I'll talk about that very soon. And the AJCC is the American Joint Committee on Cancer, which divides all cancers into stages from 0 to 4, incorporating each stage TNM stages, usually with same prognosis. So let's take the TNM staging of malignant neoplasms, a stage and a definition. So when you take TIS, that is in situ, non-invasive, confined to the epithelium. T1 has to do with small, minimally invasive, within the primary organ site, and T2 larger, more invasive within the primary organ site. T3 larger and invasive beyond the margins of the primary organ site, and T4 very large and very invasive, spread to adjacent organs. NO or N0, there's no lymph node involvement. N1 regional lymph node involvement. N2 extensive regional lymph node involvement. N3 more distant lymph node involvement. M0 no distant metastasis, and M1 distant metastasis. So that is one thing I have to. So TNM staging of the malignant, if it is T1, like I said, you get to know where it is. If it is T2, T3, T4, N0, N1, yeah. So that will help you know where the I help you with the prognosis of the tumor and even with the management of that particular case. So with the survival and prognosis, note that it's based on the grade and the stage of a given neoplasm. So a statement can be made concerning the survival after a specific period, usually 5 years or lower, due to the prognosis and from the staging. So the survival is equal to the percentage of patients with a given type of tumor of same grade and the stage treated in the same manner who live to be able to or who will be alive for 5 years after diagnosis. And it varies for different types of tumors, and the higher the 5-year survival rates, the better the prognosis. So for tumors with good prognosis, the survival ranges or rate is 10 years, and for those with bad prognosis is 2 years, 1 year, or even 6 months survival rates. And these are quoted, especially in cases like hepatocellular carcinoma. It's just 6 months survival in about 20% of the cases. So for some tumors, survival for longer than a particular period implies a cure, while in others, death may still ensue even after a long period of remission. All right, so that's something brief about neoplasia.